Hello, I'm Jeff Curtis, a rheumatologist at the University of Alabama at Birmingham. Full disclosure, I'm not a disc jockey, but if I was a DJ, I would probably, at least at times, reach for music that's familiar and comfortable that everybody likes. So if this were research, though, what kind of a study would that be? Well, probably a treat-to-target study in arthritis. You're familiar with Ticora, kind of dated now, but the concept, of course, is very familiar, and you could hum that tune. Then we had TICOPA, tight control and psoriatic arthritis. And to complete the triad, we've got the third verse, same song, but not quite the same as the first. So this is TICOSPA. So this is the spondyloarthritis version of the tight control trial that may seem quite familiar to you. But let's look a little bit past the melody line and think about how it's different. It's coming out of Europe. And one unique aspect to it is it's primarily done in centers that are experts in the management of spondyloarthritis. This is not a large pragmatic trial. This is not routine care, not really, because the centers that are participating in Europe, and there are only 18 of them, are not your average run-of-the-mill community practice centers. It's 160 patients. Now 90% completed, and so that's a total of 144. And the interesting feature of this trial, TICOSPA, is that the sites themselves were randomized. You might ask, why would you do that? You would do that, and you randomize sites when there's the threat that you basically have contamination at the site. Contamination meaning that docs overall are going to get used to doing things in a certain way. So if you have a protocol that's in place that's supposed to be on your mind at any given moment about escalating and measuring things, it's going to be hard for you not to do that, even if this is a usual care arm. So that's the contamination part. It's that your practice behaviors will be contaminated because for some, but not all patients, they're supposed to be getting this aggressive treatment that is metric driven based on disease activity. That's why you randomize sites or clusters. You do pay a statistical penalty when you do that. You have to control for that clustering, and those observations are not independent. So you typically need a somewhat bigger sample size to take care of this so-called design effect, where patients clustered or nested within sites are more alike and aren't truly independent. And there's statistical ways to account for that, but you are going to need a somewhat bigger trial. So what's the intervention? Well, the intervention is what its name might seem for it to be. It's tight control. In this case, tight control meant we're going to take biologic naive people who meet ASAS criteria for spondyloarthritis, and they're going to have a tight control protocol applied at that center. They're going to see the rheumatologist once a month, every month for a year, and there's going to be a treatment escalation protocol according to a disease activity measure, the ASTAS, that frankly most US rheumatologists don't measure in spondyloarthritis patients. The interesting thing about this trial, they didn't use the same measure to escalate care as for their outcome. That's actually a strength because otherwise, if you're using the same measure, if this was the DAS28, for example, in RA, it becomes a little bit self-fulfilling if you're escalating according to a number. Of course, that number should be better at the end of the study in the intervention arm. So these investigators, I think, took the high road, and they're measuring something at the end that isn't quite the same thing as their escalating treatment to look at the outcomes. They also looked at a variety of other outcomes, and it's a bit of alphabet soup. Bottom line, what did it show? It showed that overall, for the primary outcome, there wasn't a significant difference. There wasn't a significant benefit in the tight control arm. The difference in their main outcome, which was the ASAS health index, which is kind of a global measure of disease activity as it affects overall patient function, there was a delta of roughly 10 to 15% in that outcome and multiple other outcomes. So not trivial, but it's not an amazing difference. The primary outcome wasn't statistically significant. The p-value was 0.09. Some of the other things like the ASAS 40, again, the delta 10 to 15% range. So modest, probably clinically relevant between groups, but not extraordinary and overwhelming. One has to think implication-wise though, do patients even want to come back once a month? The other thing that you need to consider is, what proportion of people needed biologic therapies? These are biologic naive individuals. They could have been on NSAIDs. Maybe the alternative approach, just put everybody on a biologic that has spondyloarthritis. If you had spondyloarthritis, that's maybe what you would want. Give me my best shot of doing great. So in the intervention arm, 57% of people went on a biologic, so clearly not everybody, not even most people. There's, just over half. In the usual care arm, it's about 27%. So the fact that not everybody got put on a biologic, and not even most people in the intervention arm, to me, it makes good sense to rebut the notion we should just put everybody on a biologic and not worry about measuring stuff and having them come back a lot. So I do think that that was another strength. They did a health economic analysis. Not surprisingly, from the healthcare perspective, you spend more money in the intervention arm if you're going to use a lot more biologics. But because it wasn't everyone, there was a fair amount of thought applied. So bottom line, I think this is a helpful trial. It rounds out the triad of tight control in RA, psoriatic arthritis, and now spondyloarthritis. In terms of the practicality of it, are US rheumatologists going to do this? Probably not exactly, and I doubt most are even measuring, the ASTAS or the ASAS or anything else in a formal way. On the other hand, having a discussion with your patient, here's what remission or something close to it or minimal disease activity looks like. Let's talk about that, and let's keep changing treatments till we get there. We want you doing well, not just doing better. That's the notion here. I think that concept is generalizable and should resonate with patients. It'll take a little bit of extra time to explain, but I think that the results from this trial suggest that patients are actually going to feel better, their function's going to get better if you're adhering to the principle and the main concepts, even if the implementation in your own practice might look a little bit different. Thanks for your interest.